Well, for people who do not know me, I am Dr. Yahya Ithawi, and I'm a pediatrician and neonatologist. And today our talk will be about drowning or submersion injury, and it's an episode of series of talk about pediatric. Our topics is always about emergency and urgent care. So the objectives of today's talk is introduction and terminology, and then epidemiology, risk factors, pathophysiology, and end organ effects, management, outcome, and prevention. And we'll try to answer some questions at the end of the talk. So obviously, drowning is a common problem worldwide, and it's about 500,000 deaths per year. And non-fatal drowning are probably several hundred times more than this number, but mostly the number is not there because mostly not registered. And the management of non-fatal complications like hypothermia or acute respiratory distress syndrome, RADI, or complication of scuba diving and trauma will be discussed here. Now, drowning has multiple definitions, fatal drowning, you don't need definition. It's drowning end by death, but non-fatal drowning is a really problem. So here I'm going to discuss few definitions. The first one is survival, at least temporarily, after suffocation by submersion in a liquid medium. And when we said suffocation, we mean associated with loss of consciousness. Other definition, less common, survival, at least temporarily, after aspiration of fluid into the lung, or what we call it wet drowning. Somebody asked. No, there is a voice. There is a clear voice. You're late. We said if you have a technical problem, then join early, please. So survival at least temporarily after aspiration of fluid. And when we say aspiration, it's a drowning aspiration. So mostly it's more than 11 ml per kg. And usually the death drowning usually is 20 ml per kg. And it's significant if it's more than 3 or 4 ml per kg in the lung. So when we say aspiration, we mean more than 11 ml per kg. The other definition is an after period of asphyxia secondary to laryngospasm, or what we call it dry non-fatal drowning. So somebody submerged in the water, but his larynx contract and prevent the water from coming into the lung, but also the patient or the victim has asphyxia. So here is one definition about wet non-fatal drowning, and here is another definition about dry non-fatal drowning. Now, the old definition of near drowning is not in use anymore because, and the reason for these differences in definition is for reporting, because people need to report this or this. And to report, we need names, a clear definition. And that's why these are the best definitions. There is autistic guidelines of drowning. Define drowning is a process resulting in primary respiratory impairment from submersion or immersion in a liquid, which means you don't have respiration. Either there is respiration and somebody filling that, or there is a laryngospasm and you cannot respirate after you submerge in a liquid. Now, autistic, when they discussed in 2004, the ambiguous term or confusing terms such as near drowning or secondary drowning or wet drowning is not in use anymore. I want to ask anybody who is not hearing me, because somebody is insisting no voice, and he joined late. So please tell me if you're hearing me.
Yes, it's clear.
Okay. Thank you. Okay, good. Thank you. Okay, sounds clear. Okay, thank you very much. And guys, don't forget to mute yourself. Okay. So more participant is coming. So now epidemiology is drowning is very common. Whether these data comes from United States or from other country, it's very common process. And the fatality is very high, especially for those from middle income countries. For many reasons, they don't use safety tools and prevention strategies, and also unavailability of immediate medical care. So the death over there is almost like 90%. And the death is more common in male, and in America is more common in African American, and more common in young, and more common in low social economic status, and more common in summer, because obviously people try to swim. There is bimodal age distribution. Those who's less than 5 years, usually they drown in swimming pool, in bathtubs, and in containers. And the main reason is inadequate supervision, but also is intentional drowning kids, or because of neglect. So these are most common in babies or in children less than 5 years. For those in adolescent period approaching adult, the main reason of drowning is rivers, lakes, and beaches. And these people, because they are young, they're active, their energy is high, usually they are risk taker. And at this age is more in male for that reason, because obviously most of ladies, they usually do not take risks. Risk factors: inadequate adult supervision in children less than 5 years, or inability to swim, or sometimes one of the most important cause of drowning, especially in adolescents, is overestimation of the swimming capabilities. Also, as we take in adolescent, risk-taking behavior and use of alcohol and illicit drug. Also hypothermia, when it's cold, that it lead to rapid exhaustion and cardiac arrhythmia, or it depends, hypothermia start before or after, we'll talk about it. If there is concomitant trauma while you're swimming, or there is stroke, or there is cardiac incident. Also, seizure and epilepsy is a very common problem, especially also developmental and behavioral disorder in children may contribute to drowning. Also, sudden cardiac arrhythmia is very common, like prolonged QT, or certain mutation in the heart that leads to arrhythmia. The other common problem that you see is what we call it hyperventilation. So people, when try to dive, they start to hyperventilate, thinking they will get more oxygen. However, when you hyperventilation or rapid breathing has nothing to do with oxygen. What it only does, it takes or blow out CO2. So it takes CO2 out. But your oxygen will remain same, because remember, oxygenation depends on PEEP. So whether you are breathing or not breathing, it's your PEEP giving you the oxygen, not inhalation and exhalation. So the CO2 drop, oxygen remains same. They swim, they start to use oxygen. Their oxygen drops to about 30 to 40. Then, because there is no ventilation, CO2 increased. When CO2 increases, the main cause of CO2, the main cause of our ability to breathe is CO2. So when your CO2 goes up, you start to hyperbreathe. When your CO2 goes down, you start to hypobreathe. For example, if you go to high altitude and your CO2 goes up, then you start to repeat breathing. Same would happen here, because your CO2 drops, accumulate, and then you start to breathe fast. When you breathe fast, because your CO2, you want to breathe fast, then while you are in, it triggers you to breathe fast or to start breathing, and then you inhale the water. So again, hyperventilation and rapid breathing prior swimming is not good. So when you do, when you submerge, of course your oxygen drop, then you get cerebral hypoxia, you might get seizure. And of course, when you lose your consciousness, it depends what stage you are, whether you are wet or dry drowning, which means whether your laryngospasm, larynx is in spasm or not, then you lose consciousness and you'll end with either wet or dry drowning. Now, what is the pathophysiology after you submerge and then your oxygen goes down and your CO2 getting higher and you get stimulation to breathe, you get panic. When you get panic, you lose your breathing pattern. You tried, because you are inside, you try to hold your breath, but you have air hunger, there is oxygen. So it's struggle by victim to stay above. When that happened, the victim tried to haphazard movement to go up. And when he or she does that, it loses her floating features, and then it will sink down more. So reflux inspiratory effort cause hypoxemia, and hypoxemia result in aspiration. There might be reflux, as we said, in dry drowning. There might be reflux laryngospasm when the water, the first drops of water contact the lower airway. And of course, hypoxemia affects every organ. Now, the difference between salt water and fresh water is really not important. I'm going to explain it. Like in surviving and management is not important whether you are drowning in a salt or fresh clear water. But I'm going to explain it just for purpose of explanation. When you're salt water and your lung, and the water goes to your lung, obviously the salt water concentration is higher than plasma. So the plasma would be considered diluted. And therefore the fluid moves from the plasma to the lung, to the interstitium. And therefore you get massive pulmonary hemorrhage, and the fluid in the vascular system get depleted. So you get hypovolemia, hypertonic serum with massive pulmonary edema. In fresh water, the opposite. The water is less concentrated than plasma. And therefore the plasma considered it will because the concentration, it considered high concentration to the water, and water considered diluted to the plasma, and the water move from the lung to the circulation, and you get hypotonia and over circulation, and probably you will get volume overload, and then you will get also disturbance of electrolyte. Difference between salt and water or fresh water on arrival and death, and the clinical status on arrival to emergency is no difference. Aspiration of more than 8 ml per kg when you aspirate more than 11 ml per kg, you will get blood volume change. When the aspiration reaches 20 ml, 22 mil, you get electrolyte disturbance. Very unusual for non-fatal drowning victim to aspirate more than 3 to 4 mil. So very unlikely that when you aspirate more than when you aspirate more than 5 mil, you don't die. Distinction between salt and freshwater drowning, as I said, it's not considered important at this point of management, unless, because both of them you get decreased lung compliance, you get ventilation perfusion mismatch, and you get intrapulmonary shunting. What does that mean? You get edema, or you get fluid in your lung, and there is no oxygen, there is no gas in the alveoli. Blood comes from the artery, pulmonary artery, through the capillary, contact the alveoli and leave. If there is no alveoli, because there is no oxygen, because it fills, so the blood will come from pulmonary to capillary to the venous, and you get intrapulmonary shunt and result in hypoxemia, and probably when there is low oxygen, you get end organ damage. Now, the temperature of water, and if there is contaminants in the water, may affect the patient outcome. Hypoxemia, as we said, tissue hypoxia in all tissue and organs. And if somebody wants to look at ATS, this is the website. And it's very good website in accessing up-to-date information about drowning. Now we'll talk about end organ effect. First, on the pulmonary. When there is fluid in the alveoli, no oxygen, you get hypoxemia. Because both salt and water contain no protein, or maybe may contain protein, but has no fat, so it will dilute the surfactant. So it will wash out surfactant, because surfactant is fat, to prevent stick of alveoli. Because of edema, non-cardiogenic pulmonary edema, and absence of surfactant or adult respiratory distress syndrome. This results in pulmonary insufficiency. Pulmonary insufficiency can be slow or can be fast. And the rapidness of this process lead to signs and symptoms. So again, salt and water, fluid cause hypoxemia. Water wash out surfactant with pulmonary edema and adult respiratory distress. All result in pulmonary insufficiency. Rapid or slow lead to symptom, which is shortness of breath, crackles, wheezing. If you do chest X-ray or CT scan at presentation, which is obviously not necessary, it can be normal, or you can have localized or perihilar or diffuse pulmonary edema. And this is an example of diffuse pulmonary edema, which is more obvious on the right side than on left by a CT scan. The effect on the brain, again, hypoxemia and ischemia, because hypoxic ischemic. Cerebral edema will result, and you'll have increased intracranial pressure. And about 20% of non-fatal drowning, whether it's wet or dry, will result in neurologic damage. When you have neurological damage, it will limit your functional recovery despite very active and good cardiopulmonary sustain. The effect on the heart you might get initially arrhythmia, mainly because of low temperature and low oxygen. Can be sinus tachy or sinus brady or atrial fibrillation. When you do swimming or diving, when you hit the water, you might get fatal ventricular arrhythmia. For those whose heart is not normal, who they have long QT, if you do ECG, for all non-fatal submersion, you might see myocardial ischemia. The most important type of this ischemia is what we call it Takotsubo-cardiomyopathy, which is acute stress cardiomyopathy is the other name. And it's described, I think, can't remember the date, let me see. Acute stress cardiomyopathy or broken heart syndrome or apical ballooning syndrome, and it was first described in 1990. Also, when you get non-fatal submersion and myocardial ischemia, it might be due to coronary spasm. Hypothermia, you might also get, might have some myocardial ischemia property. So we talked about pulmonary, neurologic, and heart. Now we'll talk about acid-base status and electrolytes. You can get metabolic or respiratory acidosis. And respiratory acidosis because of inability to ventilate, you get high CO2, or metabolic because of electrolyte disturbance and dilution. Usually there is no significant electrolyte imbalances in non-fatal drowning unless you reach, as we said, when you reach 11 ml, you get hypoxemia, but when you don't have electrolyte disturbance unless you reach 22 ml per kg of fluid in your lung, and this usually very late. And unlikely you survive after this period, and therefore you don't see the electrolyte. However, if you drown in the Dead Sea, which is near Jordan, because it's very high salt, then you might get hypernatremia very quickly. In that situation, you might see some electrolyte disturbances with drowning of less than 11 ml per kg. So again, it's very unlikely to see electrolyte disturbances unless you get about 22 ml per kg of fluid in your lung. At that point, you rarely survive, and therefore you don't see electrolyte disturbance. Electrolyte disturbance does not occur at a level of 11 ml per kg, which is the level that causes hypoxia. And therefore, most of the patient comes with hypoxia if they are non-fatal, unless you swim in a very salty place. The other effect, we talked about pulmonary, neurological, cardiac, acid-base status, and electrolyte. Now renal. Renal failure, because it's very acute, it's very rare. But it only causes acute tubular necrosis from hypoxia or shock or hemoglobinuria or myoglobinuria. But it's very rarely to get renal failure, but you might get acute tubular necrosis. The other system effect is coagulation. So you might get hemolysis, you might get coagulopathy, but they are very rare in non-fatal drowning because they only occur when the drowning or the amount of the fluid in the lung is more than 20 ml per kg. The management divided into 3 phases. First is pre-hospital, second in the emergency department, and third in the after emergency inpatient care. So whether it's PICU or it's a general ward. The pre-hospital care and acute inversion is very vital. It's probably the most important. The rescue and immediate resuscitation by the bystanders who already are there will improve the outcome of the victim dramatically. So you have to start, or they have to start, CPR, cardiopulmonary resuscitation, whenever the safety of rescuer is guaranteed. So you don't need to reach at the beach. You don't need to reach at the bank. Even if you are in the water, you can start if you are sure or guarantee your safety. So you don't need to wait CPR until you clearly remove the patient from the water. The most important is to make sure that you start CPR and then start ventilation. When you reach the shallow and you can secure your safety and you can secure the clearance of the mouth and the nose of the patient or the victim, you have to start CPR and give the rescue breathing. When there is no heart rate, immediate chest compression, according to the CPL. Fast, more than 1/3 of the chest anteroposterior now. When you start your CPR and you make sure that you're doing, you have to give 2 rescue breath. And rescue breath mean either from the mouth or the nose, and you have to see the chest raising. So CPR, rescue breathing, and you might need to give DC shock using automated external defibrillator, AED. Remember, cervical spinal injury is uncommon unless you see on during your assessment on the victim there is signs of injury, or the mechanism of the drowning, like somebody jumped into a shallow water. Therefore, routine cervical spinal immobilization is unnecessary. However, remember, when there is altered mental status because of drug or of alcohol, remember that removal of the spinal immobilization is should be judicious. You have to think about it. When you have life-threatening arrhythmia, you go with ACLS protocol. So shockable, non-shockable, tachy, brady, and then you manage accordingly. Remember, pulses may be very weak and difficult to palpate in hypothermic patient because of sinus brady or because of atrial fibrillation. I'm not sure why you guys attend a lecture and you have a children with you. Just not attend. You don't need to attend when you have a children. So careful search for pulses for at least 1 minute is very important before you start compression in patient or in victim with low temperature. Heimlich maneuver or other postural drainage to get the water from the lung is unnecessary. You don't need to take the water outside the lung. It's very unnecessary. The most important, you start CPR and you give rescue breathing. If you have shock rhythm, give DC shock. If it's available, give oxygen. If the patient or victim is not breathing and you can intubate, then do. When you have hypothermic patient of a temperature less than 33 degrees Celsius, you have to rewarm the patient. The rewarming can be passive or active. And it's exactly like the rewarming that we talked about in cooling hypoxic ischemic encephalopathy in neonate. When the patient or the victim reaches the pediatric emergency department, you continue same pre-hospital resuscitation measures, which is making sure that you're securing the upper airway, whether invasive or non-invasive ventilation. Indication of invasive ventilation is neurologically deteriorating or inability to control the upper airway, or your inability to maintain your PaO2 if you have done blood gas to more than 60 millimeter mercury, or you cannot keep your SAT more than 90 with very high flow or CPAP or any non-invasive ventilation. Or when your CO2 is more than 50 and that means patient cannot ventilate. PaO2 less than 60, saturation less than 90 with non-invasive measure, or CO2 more than 50, an indication for intubation, or cannot manage upper airway, or clinically neurologically deteriorating. So these are extra measures that you can do at emergency that cannot be done outside the hospital. Again, when you arrive, you put nasogastric tube to decrease gastric distension, which is a super common problem in non-fatal drowning, and it can affect the result of your management. So it's very important to pass nasogastric tube. Always when you treat or ventilate patient victim of drowning, make sure that your saturation is always, like any adult, more than 94. So be liberal in providing oxygen. If you need to give oxygen by non-invasive measure or by oxygen supplement, and you need more than 30% FiO2, then move to non-invasive ventilation, whether CPAP or advanced CPAP or bilevel CPAP. If with these and FiO2 requirement is more than 40 to keep this SAT, then obviously you need to extubate. It's very vital that you monitor the blood pressure. If you don't have an arterial line, during which you will be able to manage when you have one, you can observe or monitor the blood pressure continuously. If you don't have an arterial line, then you need to measure the vital signs, including the blood pressure, hourly. In emergency, you continue to assess oxygen saturation. You might put end-tidal CO2. We've discussed the end-tidal CO2 when we talked about respiratory and ventilation monitoring. You might put a cardiac monitor, and you need to check glucose on arrival and very frequent. You think of naloxone if you suspect opioid intoxication. When you've done your A, B, C, D, E, so you secure your airway, your breathing, your circulation, your disability, and your exposure. Make sure also that you check for trauma. You might need to do appropriate imaging to check the trauma. Remember your spinal injury, which is usually very common, unless very concerning history or the patient was intoxicated, or you can see external signs on your victim suggestive of spinal, cervical spine injury. So when after you've done A, B, C, D, you reach your E exposure, so you remove any wet clothing and you start rewarming the patient. There is active and passive. Example of passive and active external is application of warm blankets, plumbed garments, or garments that have some water inside it, heating pads, radiant heat, forced warm air, or active internal core rewarming, like humidified warmed oxygen, heat irrigated peritoneal and pleural cavity, irrigation of the bowel from up or from the rectum, irrigation of the bladder, and by the end is endovascular, so doing dialysis with warm salician and extracorporeal rewarming. Very heroic, unnecessary measure to do extracorporeal, and there is no difference in survival rate between centers who do the extracorporeal rewarming and those who do not. Remember, when there is hypothermia, it might cause a neuroprotective effect. And therefore, there is incidence with complete recovery with accidental hypothermia and cardiac arrest, despite the need for prolonged resuscitation. When you have hypothermia, but some people are insisting on using nicknames, despite zillions of times we've said nicknames are not allowed. So prolonged resuscitation effort may be worthy when you have hypothermia, and it's very unlikely, but it's been reported that they continue resuscitation for hours and the patient recover because of hypothermia. And remember, although resuscitation should be for 10 minutes, but you should not stop resuscitation unless your core temperature is 35 degrees Celsius. And sometime you need low reading thermometer. The thermometer can read low temperature, which is usually not available in routine care. As we said, prolonged resuscitation should be prolonged if we expect cold water. Data is very limited about the importance of cold water, and therefore scholars are questioning the effect. But in general, outcome is very poor, whether it's poor neurological outcome or death when recovery does not occur within 30 minutes after starting resuscitation. When your patient is recovering, or when you receive the patient in the emergency, you have to do triage and decide the disposition, the discharge, to keep the patient or to discharge the patient. So you divide the patient into two categories. Symptomatic, you should always monitor, until these symptom disappears. Asymptomatic and symptomatic, both of them, you have to do ECG, you have to check the electrolyte, the renal function. If you are adolescent, think about alcohol and illicit drug. But, so these are for any patient who comes to you, whether he's symptomatic, history of drowning, ECG, electrolyte, creatinine, and these. But if the patient's symptomatic, you add for it CBC and PT. Additional testing, if you have signs of hypoxia, you might ask for troponin to look for hypoxic damage to the heart. If the patient is asymptomatic and you did your test, which is the ECG, the electrolyte, and the renal function test, you observe for about 8 hours. If no deterioration, then send home with follow-up. Before you send home, check vital sign, check oxygen. Maybe you include X-ray if there is symptom. And then there is no deterioration, you send home. Of course, as I said, you have to organize follow-up and give very clear verbal, but it's best to write it also down for the patient when to return to the emergency. When a respiratory or any other symptom develop, and the instruction should be that patient should be accompanied by a responsible adult. When you admit the patient from the emergency, we're doing only supportive care. And we'll start to treat the end organ damage, neurological, respiratory, cardiac. So you have to decide, is the patient going to the ward with vital sign monitoring or going to PICU after emergency when you need intensive care? The outcome of neurological injuries depend on the duration of losing your consciousness. And what is the neurological status on presentation? The goal in non-fatal drowning is to prevent neurological injury, which is ischemia, and therefore you have to provide respiratory support, oxygen, non-invasive ventilation or invasive ventilation. Prevent cerebral edema, all the measure you have to take from fluid or using specific measures. Good tissue perfusion for ischemia. Manage the fluid and electrolyte imbalances effectively. Make sure that your acidosis recover. And if there is seizure, treat it aggressively. So you might think of elevating the head after you excluding the cervical spine injury. You elevate the head by 30 degrees. You might think of intracranial pressure monitoring, but usually it does not affect the outcome, so rarely done. If you have signs of elevated intracranial pressure, you might need to do more aggressive measures, like diuretics, if you have clear water drowning and there is hypervolemia. You need always to avoid hypovolemia because it will decrease your cardiac output and therefore it affects your cerebral perfusion. More aggressive measures to increase it are when there is imminent danger of herniation and cooning, like hyperventilation as a temporary measure to decrease intracranial pressure by decreasing CO2 and decreasing intracranial flow. Avoid prolonged hyperventilation because it can cause vasoconstriction and decrease cerebral blood flow and worsening cerebral ischemia. When there is seizure, treat it very aggressively because it increases oxygen consumption, increased blood flow, and always use a non-sedative anticonvulsant like phenytoin. Try to avoid phenobarbital or midazolam or lorazepam. Always keep your patient conscious. because making your patient sedated will affect your neurological assessment. Avoid muscle paralysis. Avoid hypoglycemia. Avoid hyperglycemia, and try to keep your patient euglycemic. And that's why you have to measure the sugar very frequent. As we said, therapeutic hypothermia, the effect is unclear. Some said it's affected, some said it's not affected. You have to develop your institute guidelines whether to do hypothermia or not. It's very rational to do it, and it's very rational not to do it. But always you have to avoid hyperthermia, because hyperthermia increases metabolic demand and decrease the threshold for seizing, and you might have more common seizure. As we said, barbiturate used with hypothermia, some said it's good, others said it's not good. So after we've talked about neurological management on admission, now respiratory. Repeating X-ray is not necessary. So if you have symptom, you do one X-ray. Lung ultrasound is very good. Lung ultrasound is very good also on this point. And indication of imaging are increasing respiratory distress, decreasing saturation, or increasing your CO2. When you have a bronchospasm, treat it like acute asthma. Most of bronchospasm in drowning improve very dramatically with bronchodilators. There is no good evidence to use corticosteroid or prophylactic antibiotics unless you submerge in contaminated water. When you start antibiotics, cover the Aeromonas, the Pseudomonas, and Proteus. So broad spectrum with more gram-negative coverage is a good choice. When your ventilation deteriorates, you gave oxygen, you gave non-invasive ventilation, you might reach the point you have to ventilate. When you ventilate, because if it's a pulmonary edema, use low tidal volume. Don't go on high tidal volume. And if you remember ventilation, keep your plateau, inspiratory plateau or P plate low, less than 30. Because when you keep it low, you don't cause alveolar hyperinflation. And you improve your airway. So it's very important to remember this when we talked about ventilation. If you don't know it, go to the ventilation lecture and look at it. What does that mean? So keep your P plate or plateau phase, which is the second phase of the inspiration from the top of PIP to the plateau phase, which represent the airways, and from plateau to the CPAP or to the PEEP represent the alveoli. So keeping it low will increase the inspiratory time and drop the time of hyperinflation of alveoli because of the edema, so you avoid alveolar overdistension. Two principles here. Avoid high tidal volume. Try to make P plate or plateau phase as low as possible. ECMO is unnecessary. Now, you will say that there is water in alveoli, and this alveoli damage or remove surfactant. So why we don't give surfactant? Well, makes sense. You can give surfactant. However, the study shows no evidence of benefit. So you can use it, but Very important, hypovolemia. When you drown in salty, because the water will move from the circulation to the lung. Especially when you submerge in cold, because cold causes diuresis. So you have a salty water and cold water, then you get hypovolemia. So early phase, there is vasoconstriction, and the blood moves to the core. The central receptors of the vascular system sense the fluid overload, decrease antidiuretic hormone production, and cause cold diuresis. So we've treated neurological damage, we've talked about respiration, we've talked about the blood pressure. Now, of course, when your blood pressure is low, you need to make sure your volume is good and talk about your inotropes. Now we'll talk also about hypoxic damage of the heart. It's very important to avoid hypotension and to use appropriate dopamine for peripheral vasoconstriction. Make it always low dose at 10 mic, don't exceed that. Add dobutamine if you do your echo and your global eyeball contraction of the heart is not optimal. You might consider others like milrinone if you have pulmonary hypertension, but remember, milrinone will cause more hypotension. Or you might consider the vasopressin, but remember, vasopressin causes hyponatremia. So you have to decide which inotropes you use, and you have to make sure you know what you're doing. Outcome evidence is very limited. The following associated with poor outcome. The most important is the time. So if the time is more than 5 minutes, then the prognosis is poor. And about 20% of cases are more than 6 minutes. So already it's poor. If the time from drowning to start CPR is more than 10 minutes, or if the resuscitation lasts more than 25 minutes, if the age more than 14, because usually it's a risk-taking behavior and alcohol and illicit drug, or the age is less than 6 years, because usually people will not recognize it. When your Glasgow coma scale is less than 5, or otherwise, or in other words, you are comatose. When you are not breathing, when there is need for CPR at emergency, or when your first arterial pH is less than 7.1. Remember, cold water decrease metabolic demand, activate diving reflex, which is shifting of fluid, and also it causes reflex brady, breath holding, and then shunting the blood to the vital organ. So it's very important to remember, when it's a cold water, blood will go to the vital organs, and therefore the survivor is better, theoretically. However, studies showing no difference between temperature of the water and the outcome. What do you mean by good outcome? No mild or moderate neurological damage or sequelae. Remember, when there is drug or alcohol, the outcome usually bad. What's bad outcome? Death or severe neurological damage. Survival, very difficult to predict. Some studies suggested about 75%. And about 6% there will be residual. We're talking about non-fatal, of course. Number of neurological impaired survival is increasing because of the resuscitation. And care of non-neurological complications are improving, which non-neurological mean respiratory, cardiac, electrolyte imbalance, blood. And therefore, but mortality is around 74% in total. This is non-fatal. 4% will survive with severe neurological disability. There is no clear evidence when to stop the resuscitation. When you will have poor outcome, if you have absence of spontaneous breathing within 24 hours. And that's mean either you end in death or there is severe neurological damage. How we prevent? In young, less than 5, the most important is fencing and gating of swimming pools. This will exclude virtually or literally all the children below 4 years from being drowned. And it can effectively decrease drowning in a swimming pool by about 80%. That's the most, but also adult supervision, which is not good because usually they miss. Always do not swim alone. Use personal floating devices. When you're adolescent, do not overestimate swimming capability. Avoid alcohol and illicit drugs. And then you go in boat or you go swimming. Teaching parents that toddlers below 4 years can drown in very shallow water, like toilets or buckets water. And I am done. Thank you very much for listening. And I will open the door for questions if anybody has a question.